Hello guys, first of all, heartiest congratulations because you have cracked NEET PG, and as a medicine resident doing his post graduation, you have secured a seat in a branch which is your dream branch and is still one of the most sought after branches in medical field. But as a PG resident in medicine compared to an undergrad or an intern, a lot of things are going to change. You will be actually doing night duties, emergency calls, seeing patients, taking decisions, ordering things, executing the treatment plans, while also studying and preparing for your further exams. So there comes the first shock when you start doing your emergency duties. In the middle of the night, a sister calls, सर ये पेशेंट को ब्रेथलेस हो रहा है, जल्दी आइए. You reach the patient's bedside, and it is but obvious that when you're reaching there, you start thinking what all things cause breathlessness, what investigations we do if we face such a situation, and so on. But when you reach the patient's bedside, the breathless patient, anxious relative, the sister standing next to you to see what you're ordering, and we just go blank at times. We don't know what to do next. It's not that you don't know your theory part, but perhaps as the first year medicine PG, what you don't know is what to do with the knowledge that you already have. And don't worry, you're not alone. This happens with everyone. I've myself been in these situations in the initial parts of my journey as a medicine PG. And over the years, across different institutes, different setups, with each new batch of postgraduate residents, I've seen many people struggling with such issues in the beginning of their residency. So, what does actually change? So, first and foremost, once you become a medicine PG and start your residency, the rank that you secured in your entrance exams, be it 5 or 50 or 500, that starts becoming irrelevant. On day one of residency, everyone starts with a big zero and has to build everything right from scratch. You know the stuff, but perhaps many times we don't know what to do with what we already know. So that's the real transition from undergrad to postgrad life. From knowing to thinking, from thinking to applying what you already know in a particular patient when you're faced with real clinical issues. Because real clinical medicine is different from exam medicine. In exams, there are fixed syllabus, fixed pattern of questions, and predefined right or wrong answers to each question. Whereas in real clinical practice, the patient doesn't come with a label on forehead saying, I have got dengue, tell me how you manage dengue. I have got sepsis, tell me how you manage sepsis, and so on. So, what does a good physician do? A good physician, before anything else, is actually a very good observer. So, when faced with real patients, a good physician, or rather, I would say any good clinician, would first recognize the similarities in similar situations which we would have seen in the past. Same kind of symptoms, same kind of signs, and what it turned out to be in the past. And that's how we apply what you already know. That's how we think in a real patient related clinical problem. So, what a physician observes is basically how two patients with same disease can behave differently. How same patient with passing time can start behaving differently in spite of having the same illness over that time. And this observation in day to day clinical practice cannot be taught in textbooks. So that's how the perspective changes as a medicine PG from textbook medicine, exam medicine based on chapters and topics covered to real life clinical medicine, where you see actual patients make actual decisions and apply what you know. And that's what differentiates an average clinician from a good or exceptionally good clinician. While we are preparing for exams, it's always read this topic from this book, read that topic from that reference book, you refer to this journal article, you update yourself from up to date, this resource, that online course, and so many things. But real clinical medicine is beyond all this as well, and that involves pattern recognition. So, exceptionally good physicians are very good at pattern recognition. They are very good at analytical thinking. And along with this, they need to keep updating themselves. And while doing all this, during residency or during actual practice later on in our lives, whether we do post graduation, fellowships, or any special degrees or not, or any super specialty or not, in clinical practice, with this pattern recognition, analytical thinking, constant upgradation of our knowledge, what is also important is empathy that we show towards our patient and their families. Because after all, at the end of the day, we are real human beings treating real patients in front of us who have come with their problems to us. Because in today's era of AI and machine learning and algorithmic based diagnosis, information is never a problem. I mean, whatever information one wants can get in a fraction of a second at a click of a button, sitting anywhere that you desire. What matters is how clearly you think, how properly you analyze the information which is in front of you by observing the right signs and symptoms, by observing or analyzing the right values, and then applying that in making more accurate and better clinical decisions. Now, here comes another important aspect, that whenever you are approaching any patient or the patient's problem, the intention is always to do our best. No doubt everyone wants to do that. But there are instances where there can be judgmental errors. Yes, when we talk of clinical medicine, errors are frowned upon. We feel we shouldn't make any mistakes. That's natural. I mean, but what we also need to realize, all of us can face confusional conditions, situations where we don't know what to do next. All of us can make certain judgmental things, be it a first year resident or a final year resident or even a consultant or professor who has had 30 years of practice. The real game is not about being perfect or absolutely correct right on day one. The real game is to improve our judgment and analytical thinking to such an extent that mistakes start becoming lesser and lesser. And even if something inadvertently happens, that has to be as less serious as possible. Because after all, we deal with someone's health, someone's life. And the next important part, as far as this particular thing goes, as a medicine PG, the most dangerous thing for you to happen is to be fixated on a certain diagnosis upfront right on day one. So, what I mean with this, if we are fixated that this person has only this problem, then we try to fit in everything that we see or observe in that patient in that diagnosis. Whereas the real clinical medicine is exactly reverse. It should be that you should be able to step back and observe whether there is something in that patient or patient's reports or clinical signs which is actually not fitting in the diagnosis which I have in mind. So it is not about being fixated on a concrete single diagnosis right in the beginning, but it is about analyzing things over time so that everything starts falling in one diagnosis over a period of time. So it is important as a clinician to keep questioning yourself whether the diagnosis you made the previous day in that particular patient still remains the same or whether I need to change something, especially when the patient is not improving or deteriorating in front of us. And this, my dear friends, cannot be learned from textbooks. This has to be learned from real life clinical situations. And like I have been telling, with pattern recognitions, analytical thinking, and constant upgradation of one's knowledge. So while thinking all these things, there happened an incident with one of my PG residents. He asked me, "Sir, how does it matter whether I read a certain concept from a textbook like say Harrison or any reference book, or whether I understand the same concept in a language which I feel more comfortable with from some online or digital source or from some digital courses which are available. And I thought, yeah, he's not entirely wrong. I mean, I'm not at all saying that you don't read Harrison or the standard textbooks. But at the same time, although the core principles and teachings of clinical medicines have remained same over several decades, with changing times, the teaching methods also need to evolve. And that's what brought me to this current concept. So, welcome to the 3 a.m. Mentor. So, this is a series where we'll be discussing about the whys and the hows of clinical medicine and not just what. It is not going to be about the theory that you need to read. It is not going to be about the exam that you need to prepare. It will be about real life clinical situations that you and me face in everyday life. It could be a call for high grade fever at middle of the night, convulsions, chest pain, MIs, strokes, which labs to send, which investigations to do, which we can avoid because resources are after all limited. And what to do with a certain report once it comes back. Whether to start antibiotics or not to start antibiotics. If we are starting, then which antibiotic and why? So all such different scenarios we'll discuss with the help of real cases. Because during PG life, the first year is all about getting adjusted with the residency and survival. The second year you start understanding things better and you start building on your knowledge base which you have built as an undergrad. And in third year, you start making actual clinical decisions. So like we discussed before, there starts the main thing about changing from knowing to understanding to thinking and applying. And as a matter of intentional coincidence, I'm recording this first video of this series on exactly the same day when I started my journey as a medicine PG resident almost 15 years back. And if I go back in time, I think I would wish there was someone who will tell me this. Not what to read and from where, but what to do in real life clinical situations when you're facing a patient and his problems. So that, my friends, I call 3 a.m. moments. When you are in an emergency call, you are presenting a case to your professor, or suddenly on a routine round, the consultant turns and asks you some question and you're like, I've read this, but it's just not striking. So these are your 3 a.m. moments where you're expected to think quickly and take decisions about what to do next. And like you all know the concept of 3 a.m. friend, I wish that every medicine PG should have a 3 a.m. mentor who will help that PG in thinking with more clarity, in applying the knowledge that he has accurately in patient in front of him, and at the end of it all, making better clinical decisions. So welcome to 3 a.m. Mentor series. See you soon with our next video.